population. So if the peritoneal metastasis is detected radiologically or they was in prodigy 7. Here, known peritoneal metastasis. Next, those who did not have evidence of peritoneal metastasis, meaning they've already finished their intent treatment and they're on surveillance. So in them, you did re-look laparotomy or second look laparotomy to find out any occult metastasis which is not detectable on radiological imaging, and in them you gave HIPEC in order to treat the occult metastasis if at all present, or if you encountered any low burden disease you gave HIPEC. So those population were included in Profilo CHIP and Colopec 2. Then in high risk population for peritoneal metastasis, which was identified intraoperatively, that is patients who had perforation or obstruction, they were already T4, they had ovarian metastasis, or they had minimal synchronous nodules, that is low volume disease. Such population were included in Colopec trial. So Prodigy 7. So the French group in 17 different centers, they did this trial. It is a randomized phase 3 multicentric trial where you known peritoneal metastasis patients were taken. They underwent CRS and they were randomized into one receiving HIPEC, the other one did not receive HIPEC. So they wanted to see the role of treating regional disease, that is peritoneal metastasis. So whether some of the non-randomized trial had some promising result with CRS and HIPEC in colorectal with peritoneal metastasis. So they went ahead doing this RCT. So what were the eligibility criteria? These patients were histologically proven metastatic disease. They had peritoneal PCI index of less than or equal to 25. They would have undergone complete cytoreduction, that is R1, R2 versus R0, R1 versus R2. Those were the subcategory that was analyzed. Even patients who received neoadjuvant systemic therapy was included. This is important because they received oxaliplatin in their regimen. So, to say this trial was a negative trial, meaning they did not give any promising result. The primary and the secondary endpoint were not significant different between the control and the treatment group. That was attributed to one of this, that is oxaliplatin was already received by patients in the neoadjuvant setting. So the tumor cells became resistant and probably they did not react to the HIPEC that was given. So now what they wanted to see? They wanted to see if the HIPEC added to overall survival benefit. Then they found there was no difference. Both who received and who did not receive lived for median overall survival was 41 months. Only some days difference, 41.2, 41.7. So absolutely no difference. They wanted to see if this HIPEC group relapsed or late compared to no HIPEC. That also they did not find any difference. Initially, when they plotted on the curve, the study was observed till 5 years follow-up. So till 1.5 years, they could see some difference. Like there was gap between the curves, but beyond that, they joined, they came together, showing no difference in the relapse-free survival. Regarding toxicity, yes, the HIPEC, as expected, had more grade 3 and grade 4 toxicity. This was significant with p-value of 0.003. So, on the whole, adding HIPEC to CRS did not translate into overall survival or relapse-free survival or significant difference in toxicity. So, it was a negative trial. Then Profilo CHIP Prodigy 15 trial. What is this? Resection of
Prodigy 7 किसने किया था साना?
हाँ
7 का क्या था criteria? Like disease था कि नहीं peritoneal?
Peritoneal disease was there. Diagnosed patients with peritoneal disease, but they should have PCI of less than or equal to 25.
Okay, thank you.
Even R1, R2 were also included. In spite of all of this, that HIPEC, when they did subgroup analysis, it was not different for any of these. So, what was the caveats? They wanted to analyze what were the limitations of this study. If you go in detail, it will be like the power was 80%. One. Second, neoadjuvant oxaliplatin received patients were included. So we don't know whether the oxaliplatin contributed to resistant clones. That is one thing. Second thing, in the same setting, when they were giving intraperitoneal chemotherapy, they gave IV bolus 5-fluorouracil, which is not the standard regimen. You should give continuous. So they're not getting the standard care regimen. So these were all the flaws or the limitations of the study. So probably that is why they did not translate into any benefit with HIPEC is what they are telling.
Okay.
So but anyway, it is a negative trial. So that is why it is not incorporated into any standard guideline consensus. CRS and HIPEC, like gastripec and all, where OB HIPEC and gastripec, it is already come in NCCN guidelines. This is not a standard guideline to follow. It is still in the trial basis only. Next, what they wanted to do is they wanted to try out something like prophylactic HIPEC, in whom already patients were treated. So their criteria was these patients with here the subgroup is appendix colorectal. All these varieties are included. So it is the same for even colorectal HIPEC also. So here patients would have already got resected for colorectal cancer, probably even CRS. They would have received some form of systemic therapy. They would have completed the standard of care. Now they are put on surveillance. What is the concept of doing prophylactic HIPEC is by after doing laparotomy or laparoscopy. See, the sensitivity of imaging to pick up peritoneal metastasis is not great. So they wanted to check surgically. Either you can resort to laparoscopy or laparotomy after 6 months of your surgery to see if they have developed any unpicked metastasis on the imaging. When they did relook in this trial, when they did relook laparotomy, some like less than around 10 to 20% only had some metastasis, and it was very low burden PCI. It was less than 7 or 4, single digit. So, and some did not have also. So irrespective of that, they did peritonectomy, they gave HIPEC. In the other group, they continued surveillance only, and they wanted to see after giving prophylactic HIPEC, that is, they assumed that they have picked up disease early, and they wanted to treat even occult peritoneal metastasis. Did this translate into 3 years disease free survival? That also was a negative trial. They did not really give any benefit. So here, complete cytoreductive surgery and HIPEC, according to them, wanted it to prolong survival in at least low volume disease patients. So it's a multicentric randomized phase 3 trial where they wanted to see potential survival benefit of a systematic second look surgery plus HIPEC in those who have high risk of developing colorectal peritoneal metastasis. So this category of high risk, whom we can anticipate development of peritoneal metastasis after their completion of treatment, are perforated patients, obstructed patients, patients who have undergone surgery for T4, and aggressive biology patients are some whom you can expect them to recur peritoneum. Then their methods were the high risk patient, like how we discussed. This group underwent the standard care and they continued surveillance. In the other group, they stopped at 6 months. They opened their abdomen, assessed the peritoneum, and then gave CRS if needed, and gave HIPEC. If they did not have any disease, they still gave HIPEC as prophylactic. So it is called prophylochip trial. Then what they wanted to see is at 3 years, what was the disease-free survival. Secondary endpoints were overall peritoneal disease-free survival and post-operative complications. So in all the things, they did not find any statistically difference between the two groups. So the study confirms that criteria for high risk for developing peritoneal metastasis is strong. So this statement is given because when they went and relooked, they could find at least 33% patients have relapsed in low burden, or some had cytology positive. So they said, yes, these were not picked up by imaging. Yes, these high risk people are bound to relapse in the peritoneal metastasis, which are not picked up by imaging. Yes, we can pick up, but they failed to prove that HIPEC was beneficial in this group of patients. If you picked it up early and you treated them with CRS and HIPEC, it really did not translate into any benefit. Then coming to Colopec trial. Here, here those patients who underwent CRS, that is intraoperatively, when you went inside, it was a T4 disease, there was peritoneal metastasis, you went ahead doing CRS. In that setting, in primary setting, when you give HIPEC, this is Colopec trial. This is also a randomized multicentric study where the inclusion criteria was T4, N0 to N2, M0, or perforated colon, where there is increased risk of peritoneal recurrence, and they were assigned into those to receive HIPEC and those not to receive HIPEC, but both of them were followed up with adjuvant systemic chemotherapy. So what was the regimen followed? It was one-time administration of oxaliplatin, 460 mg per meter square for 30 minutes duration, 42 degrees, concurrent with 5-fluorouracil or leucovorin intravenously, either simultaneously or 5 to 8 weeks after primary resection. So in this group, majority of them received interval HIPEC. So the outcomes were analyzed according to the intention to treat patients. So there was no difference in 5 years overall survival in those who received HIPEC and those who did not receive HIPEC. And pretty much there was not much difference in even the mortality morbidity of the post surgery also in this group. So the inclusion was T4 N0 to 2 M0 perforated patients. They were randomized to receive HIPEC followed by adjuvant chemotherapy, or just did CRS and followed by adjuvant systemic therapy. So the extended version of Colopec is Colopec 2. So they again wanted to see if surveillance by surgery, that is diagnostic laparoscopy at regular intervals, could pick up disease early, and whether treating them at even before they manifested into full-blown or high-burden disease, whether that translated into any benefit. So here the selection criteria was all of those high-risk patients who are bound to have peritoneal metastasis. They chose them, they followed them up. At 6 months, they did CT. They wanted even to compare the concordance of the imaging and their intra findings. So at 6 months, they did CT. Then they again treated those with low burden disease and those with occult metastasis with HIPEC. That is one thing. And again, those who did not have anything or they received HIPEC, they were again followed up. They again, probably I think this is after 18 months, they again did a CT and diagnostic laparoscopy, and again wanted to confirm if they developed any peritoneal disease in this interval. So again, they repeated to give prophylactic HIPEC. in this group of patients. So this trial also, even though they could pick up some disease which is very less, like 10%, it did not really manifest into any survival benefit by HIPEC. So all of these are negative trials when it comes to colorectal malignancy with peritoneal metastasis. So only these are the 4 trials I wanted to discuss.
These are for appendicular or colorectal?
Colorectal, appendicular, colorectal, all of it.
Okay. Thank you.
Okay.
Bye bye.
Bye.